Welcome back, everyone, to another deep dive. This time, we're focusing on a topic I'm sure you're all too familiar with as general practitioners, neck pain.
Oh, absolutely. You're right on the money there. It's incredibly common.
Yeah, right up there with low back pain in terms of how many patients we see for it. But here's the thing that surprised me. Neck pain, while it's a pain, doesn't actually cause as much missed work as low back pain.
That's a good point. It's interesting, isn't it? You'd think with everything that's packed into the neck, all those important nerves and muscles, it would lead to more people being out of commission. But the data tell a different story.
Right. And here's another twist. Even when it seems like the neck pain came on suddenly, the underlying cause is often, you guessed it, those pesky degenerative changes that just kind of come with the territory of getting older.
It's like a ticking time bomb kind of lurking in there. But the good news is it doesn't always go off.
Well, we'll save the explosive stuff like traumatic neck injuries, radiculopathy, and myelopathy for other deep dives. For today, let's really get a solid grasp on the anatomy, those everyday culprits behind neck pain, and of course those red flags that tell us something more serious might be going on. Sound good?
That sounds like a plan. Where should we start?
How about a quick trip back to the basics with Anatomy 101?
All right, let's do it.
We all know it's 7 cervical vertebrae, but sometimes I think we take for granted how complex and delicate this area really is.
Absolutely. Each vertebrae with its own unique structure and way of moving and articulating with the others. It's fascinating.
So true. And I feel like it's those connections between the vertebrae where things really get interesting. I'm thinking especially that area between C4 and C7. That's where we see a lot of wear and tear, right?
You're right. That area tends to take a beating. It's the most mobile part of the cervical spine, so it just naturally experiences more stress and strain over time. Plus, we have those uncovered tebral joints in that region.
Okay, back up for a sec. Uncovered tebral joints. Refresh my memory.
They're kind of unique to the cervical spine, little bony projections on the sides of the vertebrae, and as we age, they can hypertrophy, get bigger and bulkier, which can start to press on those nearby nerve roots. That's one way radiculopathy can develop, which we'll get to later.
Got it. Makes sense. And then, of course, we can't forget the muscles. Those cervical and trapezius muscles are doing a lot of work, literally holding up our heads all day and protecting that delicate spinal cord.
Absolutely. And their health, or a lack thereof, plays a big role in neck pain.
For sure. And then there's that beautiful curve in the neck, the cervical lordosis. It's supposed to have a slight inward curve, but I see so many patients where that curve is flattened or even reversed because of degeneration.
You see it all the time. And then on the flip side, you have patients with a really pronounced curve, almost like a swan neck.
Oh, yeah, for sure. That's often tied to that hunch in the upper back thoracic kyphosis. The body tries to compensate, and it ends up exaggerating that cervical lordosis.
Exactly. It's all connected.
Okay, here's something that kind of blew my mind when I was prepping for this. All those changes in alignment, those bone spurs we see on x-rays, the flattened or exaggerated curves, they might not actually be the source of the pain.
Isn't that wild? Imaging can show all sorts of abnormalities, but they don't always line up with what the patient's actually experiencing.
Such a good reminder that a good history and physical exam are still our most valuable tools.
Couldn't agree more. We can't get too distracted by those fancy pictures.
Right, the patient in front of us, that's the real story. Okay, before we move on to the common causes of neck pain, I want to touch on one more piece of anatomy, the nerves.
Right. Can't forget about those.
8 cervical spinal nerves, each with their ventral and dorsal roots. This is where things get tricky when we're talking about radiculopathy.
Definitely key players. But those dermatome and myotome maps, remember those from way back when? They can help us make sense of it all.
Oh man, those were always like a puzzle to me.
Well, they're helpful, but they're just guides. Don't be afraid to think critically and go beyond the maps if what you're seeing in the patient doesn't quite match up.
Good advice. Okay, enough anatomy for now. Let's get to the good stuff. Those everyday culprits behind neck pain. We've got to start with the classic, right? Cervical strain.
The bread and butter. Think of it as those aches and pains from just overdoing it. Pain, stiffness, maybe a history of muscle injury.
The weekend warrior syndrome. Sleeping funny, too much time hunched over the computer.
You nailed it. Sometimes the cause is crystal clear, and sometimes it's a bit of a mystery.
Which is why that thorough patient history is so important. Asking the right questions can help us figure out what's going on and guide our treatment.
Couldn't agree more. And the good news is, in most cases of simple strain, you won't even need imaging.
So no need to rush to order an x-ray for every stiff neck that walks in the door.
Exactly. Most of the time, these cases resolve within about 6 weeks with conservative management. Now, if things are dragging on beyond that, then we start thinking about other possibilities.
So 6 weeks is our magic number.
Got it. Okay, let's talk about a term I hear all the time, but I'm not always sure what it really means. Cervical spondylosis. It sounds scary. How worried should we be about it?
It does have that ominous ring to it, doesn't it?
Mm-hmm.
But really, it's just a fancy way of describing those degenerative changes we've been talking about. Wear and tear on the discs, the facet joints, the ligaments. The thing is, we see spondylosis on imaging all the time. People of all ages, even those without a lick of neck pain.
So, it's kind of like a normal part of aging. Can we just ignore it then?
Well, not always. It can definitely be the cause of neck pain, especially if those degenerative changes are pinching a nerve root.
So that's where radiculopathy comes in.
Exactly. If we're seeing spondylosis on imaging and the patient's telling us about pain radiating down their arm and our exam findings point to a nerve root being involved, then we know those degenerative changes are likely the root of the problem. Makes sense. We'll definitely get into radiculopathy in detail later on. Okay, next up, cervical discogenic pain. This one's all about those discs, the cushions between the vertebrae starting to wear down, right?
Right. And it's important to remember, just like with spondylosis, disc degeneration is super common on imaging, even in people who aren't having any symptoms. But with discogenic pain, it's specifically those changes in the disc that are the troublemaker.
So how does that present differently from a regular strain?
The symptoms can be pretty similar. Pain and stiffness, especially with prolonged positioning. Think about someone who sits at a desk all day or sleeps in a weird position.
That's like 90% of my patients. So how do we tease apart whether it's a simple strain or true discogenic pain?
It's tricky, but there are a few clues. With discogenic pain, the pain's usually more localized to the neck, and it might get worse with certain movements, like bending or twisting. And the pain itself is often described as a deep, aching pain, different from that sharp, shooting pain of radiculopathy.
It's all about the details, isn't it? Really
Yeah.
listening to how the patient describes their pain and noticing those subtle differences.
It really is. And as always, a good physical exam can help us narrow things down.
For sure. Okay, let's switch gears a bit and talk about whiplash. This is that sudden neck injury from that rapid back and forth motion like we see in car accidents, right?
That's the classic example. But honestly, whiplash can happen from any kind of sudden jolt to the head and neck. Sports injuries, falls, even just tripping and catching yourself.
It's that sudden acceleration-deceleration force that does the damage.
Exactly. And that force can injure muscles, ligaments, and this is important, those facet joints we talked about earlier.
Ah, okay, so that's why whiplash is often labeled as a strain or sprain.
That's right. Because it's about injury to soft tissues. But here's the kicker. Facet joint injury is often the main culprit behind that upper neck pain and headache that people get after whiplash.
So it's not just the muscles and ligaments we need to think about.
Exactly. Those facet joints are really important for the mechanics of the cervical spine, and when they get injured, it can cause a whole lot of pain and dysfunction.
Okay, let's say someone comes in with suspected whiplash. What's the usual timeline for symptoms?
Well, the main symptoms are pain and stiffness, and those can show up right away or be delayed for a couple of days.
Why the delayed onset sometimes?
That's a good question. It's not entirely clear, but it might be related to the inflammation and muscle spasm that develops after the injury.
Interesting. So important to warn patients that they might not feel the full effect right away.
Very important. And besides pain and stiffness, there can be a bunch of other symptoms too. Headaches, shoulder pain, dizziness, even fatigue, and trouble sleeping. It can really impact a person's life.
It sounds like the symptoms can be all over the place. Is there a way to grade the severity of whiplash?
There is. We typically use a grading system that focuses on grades 1 to 3. Grade 1 is the mildest, just neck pain and stiffness. Grade 2 adds in some of those musculoskeletal signs like limited range of motion. And grade 3 means there are neurological symptoms involved.
Okay, what about grade 4?
Grade 4 is a whole different ballgame. That's when you have fractures or dislocations and it needs a completely different approach.
Yeah.
But luckily, most cases fall into those first 3 grades and can be diagnosed clinically. We don't always need imaging.
That's good to know. But I've got to say, this statistic really surprised me. About half of adults still have neck pain a year after a whiplash injury. That seems really high.
It's a big number for sure, and it really highlights how whiplash isn't always just a simple injury that heals on its own.
So what are some of the red flags that make us think, okay, this person might be in for a longer haul?
Initial pain severity is a big one, and reduced range of motion. The more severe that initial injury, the longer it tends to take to recover.
But it's not just about the physical injury, right? I imagine there's a big psychosocial component to this as well.
You're absolutely right. Things like social support, depression, anxiety, and even just how someone views their pain, do they tend to catastrophize? All those things can play a role in recovery. And even cultural influences come into play. Different societies have different expectations and perceptions of pain.
It's all connected. So what's actually happening at a physiological level that might explain those longer-term symptoms?
Well, that's the million-dollar question. We don't have all the answers yet. While inflammation might explain the initial pain, it's more complicated than that. There's probably a whole mix of factors involved. Ongoing inflammation, soft tissue damage, changes in muscle function, even changes in how the nervous system processes pain.
It sounds like we're still learning a lot about whiplash. What role does imaging play in these cases, especially for those folks with chronic symptoms?
MRI is becoming more and more useful in those cases. It can help us see any soft tissue damage, particularly to the ligaments in the upper neck. That can be a source of ongoing pain and instability.
So MRI might be warranted in those trickier cases where the symptoms are hanging around and we're not finding clear answers on exam.
Exactly. It can give us more information to guide our treatment decisions and help us understand why the patient's still struggling.
Makes sense. Okay, let's hit a couple of other common causes we see in practice. First up, cervical facet osteoarthritis.
Basically, it's just wear and tear on those facet joints we were talking about. The cartilage wears down, you get bone spurs forming, and that leads to pain and stiffness.
Kind of like osteoarthritis in any other joint, but in the neck.
Exactly. And it gets more common with age, just like you'd expect.
What should we be looking for in terms of symptoms?
The classic presentation is pain and stiffness in the neck, especially with movement. And that pain might just be in the neck, or it can radiate out to the shoulders or head.
Is there anything specific about the pain pattern that would help us differentiate it from other conditions?
Well, unlike radiculopathy, facet osteoarthritis doesn't usually cause those shooting pains down the arm. The pain tends to be more achy and more localized to the neck and upper back.
Good point. So if we suspect facet osteoarthritis, how do we confirm that suspicion?
It's a combination of clinical findings and imaging. On exam, we're looking for limited range of motion in the neck, tenderness over the facet joints.
And do we go straight for an MRI?
Not necessarily. We usually start with plain films of the cervical spine. It gives us a good look at the alignment, the disc spaces, any bony changes. We can often see those telltale signs of osteoarthritis on x-ray, narrowing of the joint space, bone spurs, those sorts of things.
But you mentioned earlier that we often see osteoarthritic changes on imaging, even in people who aren't having symptoms. So how do we know those changes are actually causing the patient's pain?
Ah, great question. That's where a local anesthetic injection into the facet joint can be really helpful.
Ah, so it's a diagnostic test and treatment all rolled into one.
Exactly. If that injection provides significant pain relief, it suggests that the facet joint is indeed the source of the problem.
That's a neat trick. Okay, let's talk about a condition that can be a bit of a head scratcher. Myofascial pain syndrome, or MPS.
MPS. Oh, yeah. This one's all about those trigger points, those tender knots in the muscles that can cause all sorts of pain and referred pain.
I've heard of trigger points, but help me out. What exactly are they?
They're like these hypersensitive spots in the muscle. They feel like tight bands or knots. And when you press on them, it can cause pain not only in that spot, but also in other areas.
So it's like the pain's radiating out from that trigger point.
Exactly. And it can be quite intense, often described as deep aching pain, sometimes with burning or tingling.
How do we know this isn't fibromyalgia, which also involves a lot of widespread pain?
Good question. With MPS, the pain is usually more localized to one area, like the neck and shoulders, whereas fibromyalgia is more all over the body.
So it's about the distribution of the pain. Got it.
That's one key difference. Another is that with MPS, we can often find those specific trigger points that, when we press on them, reproduce the patient's pain.
Okay, that makes sense. We'll definitely do a deep dive on MPS in another episode so we can save the treatment details for then. For now, let's jump to a condition I have to admit I don't know much about. Diffuse idiopathic skeletal hyperostosis, or DD.
That's a mouthful.
It is. So what is it?
It's basically a syndrome of abnormal bone growth. And it can affect the spine, but also other joints in the body.
So what's going on there? What's causing it?
Well, with DDSH, there's excessive bone formation, especially along the ligaments that run along the spine. You get these large bony spurs that can actually bridge the spaces between the vertebrae.
Wow, that sounds intense.
Yeah.
And what does that look like clinically? How do those patients present?
The main symptom is spinal stiffness, especially first thing in the morning. and that's often accompanied by pain in various areas. That stiffness can be really bad, and it might take a while to loosen up as the day goes on.
Is there anything unique about the pain with DIS?
It can be really variable. Some patients have pain in the neck, others in the back, some in multiple areas, and the type of pain varies too. Achy, sharp, sometimes even burning.
Sounds like a mixed bag. How do we diagnose it?
Imaging is key. On X-ray, you'll see those large bony spurs bridging the vertebrae. They often describe them as having a flowing appearance, or like candle wax.
Okay.
And these spurs tend to form asymmetrically, which is another characteristic feature of dish.
So there are specific radiographic criteria for diagnosing DISH.
There are, yep. And those criteria can help us distinguish it from other conditions that can cause similar bony changes, things like ankylosing spondylitis.
Good to know.
Hmm.
Okay, it's time to shift gears a bit and talk about those red flags. The warning signs that tell us something more serious might be going on.
The things that make us think, okay, this isn't just your average neck pain.
Right, those signs and symptoms that should make us consider those less common, but potentially more serious causes.
Exactly. So let's just run through them. What are the red flags that we absolutely cannot afford to miss?
Hit me with them.
All right, well, let's start with the most concerning one. Neck pain that comes with neurological symptoms.
So things like weakness, numbness, tingling, changes in reflexes.
Exactly. If a patient's experiencing any of those, we have to consider the possibility of spinal cord compression or nerve root involvement.
And we know that can happen with spondylosis or disc herniations, which we've talked about. But what are some of those other scarier things we need to think about?
Well, neurological symptoms could also be a sign of a tumor, an infection, or even an autoimmune disorder affecting the nervous system.
Okay, so those neurological symptoms are a big red flag,
Mm.
for sure. What else?
Fever, if it comes along with neck pain.
Why is fever such a big deal?
Well, it can indicate an infection, and sometimes infections can affect the spine.
So we're thinking about things like meningitis or osteomyelitis.
Got it. Those are serious conditions that can present with neck pain and fever, and they need to be diagnosed and treated quickly.
Fever's on the list. What else?
Unexplained weight loss, especially if the patient has a history of cancer.
Why the connection to cancer?
Well, certain types of cancer can spread to the spine, and that can cause pain and other symptoms. Unexplained weight loss can be a sign of an underlying malignancy, so it's always something to take seriously.
I see. So it's not just about ruling out a musculoskeletal cause,
Mm.
but thinking about those systemic illnesses that can show up as neck pain.
Exactly. We need to think broadly and keep all the possibilities in mind.
Okay, good point. What about some of those more vague symptoms, like headaches or shoulder pain, maybe even visual problems? Are those red flags too?
They can be, for sure, especially if they're persistent or if they come with other concerning symptoms.
So it's all about context.
Exactly. A headache on its own might not be a big deal. But if it's new, severe, not responding to the usual treatments, or if it's coupled with neck pain, stiff neck, fever, or any neurological symptoms, then it's definitely cause for concern.
What about pain in the front of the neck? Is that ever a red flag?
It can be. Pain in the back or side of the neck is more common with those musculoskeletal causes we've been talking about. But pain in the front could signal a problem with the thyroid, the esophagus, or even the heart.
Wow. So many different systems can refer pain to the neck.
It really highlights the importance of that thorough history and physical exam.
Absolutely. Speaking of which, let's get into how we evaluate a patient with neck pain. What are the crucial things we need to get from the history?
Well, the most important thing is understanding the pain. Where is it? How bad is it? What does it feel like? Does it travel anywhere?
So asking about location, intensity, quality, radiation of the pain.
Exactly. We also want to know when it started, what makes it better or worse, and if it's connected to any other symptoms.
And of course, we're asking about how it's impacting their life, their ability to work, sleep, do their normal activities.
Absolutely. And then, of course, we're going to be asking about those red flags we just discussed.
Those red flags are our guideposts, right?
Mm-hmm.
They help us decide if we need to dig deeper. Okay, so we've taken a good history. Now it's time for the physical exam. What the key things we're looking for when we examine a patient with neck pain?
Just like with any exam, we start by observing. We look at their posture, how they're holding their head, their overall body language.
Looking for any signs of guarding, wincing, any indication they're in pain.
That's right. Then we'll check their range of motion, ask them to bend their head forward, backwards, side to side, and rotate.
I always find it helpful to compare their active range of motion, what they can do on their own, to their passive range of motion, what I can move them through.
That's a good point. Sometimes there's a difference there, which can give us clues about what's causing their pain.
Okay, so we've observed their posture, checked their range of motion. What's next?
Palpation. We're going to feel for any tenderness or spasm in the muscles of the neck and upper back. And we're paying special attention to those trigger points we talked about.
Any tips for finding those trigger points? They could be tricky.
It takes practice, for sure. Feel for those tight, ropey bands within the muscle, and ask the patient if pressing there reproduces their pain.
Okay. And of course, we can't forget the neurological exam.
Absolutely crucial. We're going to be checking sensation in the upper extremities, looking for any numbness or tingling. We'll test reflexes biceps, brachioradialis, triceps, and assess muscle strength in the arms and hands.
Okay, good reminder. Now, what about those provocative maneuvers we mentioned earlier? Are those helpful when we're evaluating neck pain?
They can be. These are special tests we can do to try to reproduce or worsen the patient's symptoms. That helps us figure out exactly where the pain's coming from.
Can you give us some examples?
Sure. One common one is Sperling's test. We extend and rotate the patient's neck toward the side of their pain while applying a little bit of downward pressure. This can compress the nerve roots and reproduce that radicular pain.
So that one's good for checking for radiculopathy.
Yep. Another good one is the upper limb tension test. This involves stretching the nerves of the arm. We raise the patient's arm overhead and extend their wrist and fingers. If there's nerve root involvement, this can cause symptoms.
And then there's the manual neck distraction test where we gently lift the patient's head, right?
That's right. This can sometimes relieve that radicular pain by taking pressure off the nerve roots.
So by putting together the history, our physical exam findings, and the results of those maneuvers, we can start to formulate a working diagnosis.
Exactly. And then we can decide if we need any imaging to confirm things.
Which brings us to the big question of imaging. We talked earlier about how we don't always need imaging for neck pain, but when it's necessary.
Well, those red flags we talked about are always a reason to get imaging. So fever, unexplained weight loss, history of cancer, any neurological symptoms, those all warrant a closer look.
Okay, so those are automatic. What about those patients whose symptoms are really bad or haven't gone away, but they don't have any of those red flags?
If the pain is moderate to severe and it's affecting their sleep, their work, their daily activities, and it's been going on for more than 6 weeks, the imaging is definitely a good idea. We don't want to miss anything serious, and imaging can help us rule out those more sinister causes.
Okay, so we've decided to order imaging. What's our go-to for neck pain?
For most patients, we'll start with plain films X-rays of the cervical spine. It gives us a good overview of the bones, alignment, disc spaces. We can see fractures, dislocations, osteoarthritis, even some disc herniations on X-ray.
What if those x-rays are normal or we need more information?
Then we move on to MRI. MRI is the gold standard for looking at the soft tissues of the neck spinal cord, nerve roots, discs, ligaments, all that.
So MRI is our best bet for things like radiculopathy and myelopathy.
Exactly. It can show us how much nerve compression there is and help us make decisions about treatment.
Are there ever times when we'd go for a CT scan instead?
CT scans are really helpful if we're worried about a fracture, or if a patient can't have an MRI because of metal implants or claustrophobia. They can also give us a better view of the bones.
Okay, that makes sense. Now, what about those other tests we sometimes hear about, like electrodiagnostic tests? When would we order those?
Those tests, things like electromyography and nerve conduction studies, are useful in certain situations, especially when we're trying to tell the difference between radicular pain and other nerve problems in the arm or hand. They can tell us if there's nerve damage and pinpoint where the problem is.
So not routine, but they have their place.
Exactly.
What about lab tests? Do we ever need those for neck pain?
Not usually, but they can be helpful if we suspect the neck pain isn't coming from a musculoskeletal problem.
Like what? Give me some examples.
Well, if we're thinking about a rheumatic disease, we might check inflammatory markers, things like ESR and CRP. If we're concerned about infection, we'd need a complete blood count, inflammatory markers, and cultures.
Okay, so lab tests are more for those cases where we're thinking outside the box of those typical musculoskeletal causes.
You got it.
Well, we've covered a ton of information already. I feel like we've built a really solid foundation for understanding the anatomy, the common causes, and those red flags we can't miss when it comes to neck pain.
I agree. We've laid some good groundwork here.
And we've only just scratched the surface.
There's always more to learn. But for now, let's take a break, and when we come back, we'll dive deeper into cervical radiculopathy.
Sounds good to me. We'll see you back here soon for more neck pain insights. All right, welcome back to our deep dive into neck pain. Last time we really got into the anatomy and those everyday aches and pains. Now, I'm ready to tackle a condition that I know we see a lot in primary care, cervical radiculopathy.
It's definitely a common one, and it can be really tough on patients.
Okay, let's start with the basics. Remind me, what exactly is radiculopathy?
It's all about those nerve roots that branch off the spinal cord. So, in cervical radiculopathy, one of those nerve roots in the neck is getting irritated or compressed.
And I remember you mentioned that those degenerative changes, the ones we see with aging, are often the culprits behind that compression, right?
You got it. Bone spurs, herniated discs, thickened ligaments, all that good stuff. It can all crowd the space where those nerve roots exit the spinal cord.
So if I have a patient come in complaining of neck pain, what should make me think, this could be radiculopathy?
hmm
What are those key symptoms I shouldn't miss?
The hallmark symptom is pain that radiates along the path of the affected nerve root. So imagine a sharp shooting pain or a burning pain that travels from the neck down into the shoulder, the arm, maybe even into the hand and fingers.
So pain that's not just in the neck, but traveling down the arm. That's a big clue that a nerve might be involved.
Exactly. And it's not just the pain itself, but the path it takes that's important.
Give me an example.
Sure. Let's say you have a patient who has pain that starts in their neck and then shoots down the back of their arm and into their pinky finger.
So the location of the pain helps us figure out which nerve root might be affected.
Exactly. And that's where those dermatome and myotome maps come in handy.
Oh yeah, those maps that outline the sensory and motor distribution of each nerve root. Full disclosure, those always intimidated me a bit back in med school.
I get it. They can seem complicated, but they're really just tools to help us match up the symptoms with the nerve root that's most likely involved.
Okay, so in that example I gave, with the pain going down the back of the arm and into the pinky finger, what nerve root would we suspect?
That sounds like the C8 nerve root.
So the pain pattern gives us a good starting point. But it's not just pain, right? There could be other neurological symptoms as well.
Absolutely. Depending on which nerve root is compressed, you might see weakness in certain muscles, numbness or tingling in a specific area of the skin, or even changes in reflexes.
So we're back to those myotomes and dermatomes again.
Exactly. They can help us pinpoint which nerve root is likely involved. For example, if someone has weakness in their biceps and decreased sensation along the outer side of their forearm and thumb, we'd be thinking about C6.
Okay, it's all starting to come together now.
Yeah.
But you mentioned earlier that those maps aren't perfect. What are some things we need to keep in mind?
Well, those symptoms don't always follow those textbook distributions perfectly. There can be some overlap between nerve root levels, and sometimes patients have other things going on that can make the picture a little less clear.
So we can't just rely on the maps blindly. We have to use our clinical judgment.
Exactly. They're good guides, but a good history and physical exam are your most valuable tools.
I'm hearing that a lot today.
Ah.
Okay, let's talk about that exam. What are the key things we're looking for when we suspect radiculopathy?
Start with observation, just like always. Notice how the patient's holding their head and neck. Are they guarding their movements? Do they have limited range of motion?
I see a lot of patients who come in cradling their arm, almost like they're protecting it.
That's a classic sign that pain can be so bad that they don't even want to move their arm. After we observe their posture and movement, then we move on to palpation. We'll feel for any tenderness or spasm in the muscles of the neck, the shoulders, and the upper back.
And paying close attention to those trigger points.
Oh, absolutely. Trigger points in the neck and shoulder muscles can actually mimic the symptoms of radiculopathy, so we got to make sure we're not getting those mixed up.
Good point. Okay, and then of course the neurological exam is super important.
Can't skip that. We're checking sensation in the dermatomes that match up with the nerve root we're suspecting, looking for any areas of numbness or tingling.
And there are specific reflexes we can test too, right?
Right. Biceps, brachioradialis, triceps. We'll compare side to side, looking for any asymmetry or weakness.
And what about muscle strength?
We'll assess that in the muscles that are supplied by the nerve root we're thinking about. So if it's C6, we'll check biceps strength, wrist extension, and sensation along the thumb and index finger.
Okay, so we've got our history, our physical exam findings. What about those provocative maneuvers you mentioned earlier? Are those helpful in evaluating radiculopathy?
They can be, for sure. They can help confirm our suspicions and figure out exactly which nerve root is involved. Sperling's maneuver is a good one. That's where we extend and rotate the neck toward the side of their pain while applying a little bit of downward pressure. That can reproduce the radicular pain or make it worse.
I've heard of Sperling's, but I'll admit I'm always a little hesitant to do it. I don't want to hurt my patient.
I understand. The key is to be gentle and stop if they have any significant pain, and always explain to the patient what you're doing and why.
Okay, that makes me feel better. What are some other maneuvers we can try?
The upper limb tension test is another useful one. It involves stretching the nerves of the arm by raising the patient's arm overhead and extending their wrist and fingers.
So if we do that on the affected side and it brings on their symptoms, that's another clue pointing towards radiculopathy.
Exactly. And then there's the manual neck distraction test. That's where we gently lift the patient's head. This can sometimes provide some temporary relief from the pain.
So by taking all that together, the history, the exam, those provocative maneuvers, we can get a pretty good idea of whether it's radiculopathy or not.
That's right. And then we can decide if we need any imaging to confirm the diagnosis.
Okay, let's talk imaging. I know we talked about not always needing it for neck pain, but with radiculopathy, is it usually indicated?
It depends. If the symptoms are mild and their neurological exam is normal, we can often start with conservative management and see how they do.
So try those non-surgical options first.
Exactly. But if the symptoms are severe, or if they're getting worse, or if there are any significant neurological deficits, then we definitely want to get imaging.
Okay, that makes sense. And what's our imaging test of choice for radiculopathy?
MRI is usually considered the gold standard. It gives us that detailed look at the spinal cord, nerve roots, discs, and all the surrounding structures. We can see if there's a herniated disc, bone spur, anything that might be pressing on the nerve root.
And what if we can't do an MRI? Like if a patient has a pacemaker or can't tolerate being in that enclosed space?
A CT myelogram can be a good alternative in those cases. It involves injecting contrast dye into the spinal canal, and then we can see the spinal cord and nerve roots more clearly on the CT scan.
Okay, so we've made the diagnosis of cervical radiculopathy. Now, the big question, what do we do about it? What are our treatment options?
Well, this is where your skills as a general practitioner really come in. The good news is that most cases of cervical radiculopathy actually get better with conservative, non-surgical management.
That's good to hear.
Uh,
So what does conservative management involve?
well, first and foremost, education and reassurance are key. We need to explain to our patients what radiculopathy is, what's causing it, and that most of the time it gets better on its own with time and the right treatment.
I find that patients often get really anxious when they hear words like nerve compression.
Oh, absolutely. So it's important to address their concerns and help them understand that they're not alone, this is a common problem, and we have effective treatments.
Okay, so education and reassurance are our foundation. What else can we do to help them feel better?
We might recommend a short course of over-the-counter pain relievers like ibuprofen or naproxen
Yeah.
to help with the pain and inflammation.
Those are good first-line options. What about prescription medications?
If those aren't doing the trick, we can consider prescribing stronger pain relievers or muscle relaxants.
I know there's been a lot of concern about opioid overuse. Any guidelines we should keep in mind when we're prescribing those for radiculopathy?
Absolutely. Opioids should really only be used as a last resort and for a short period, and we need to carefully monitor our patients for any signs of misuse or dependence.
It's a fine line to walk. We have to weigh the risks and benefits very carefully.
For sure. And we can't forget about physical therapy. That's a cornerstone of conservative management.
What's the role of physical therapy in these cases?
A good physical therapist can teach our patients specific exercises to improve their range of motion, their posture, their core stability. They can also help strengthen the muscles that support the neck and take pressure off those nerve roots.
So it's not just about pain relief. It's about addressing the underlying mechanics and improving function.
Exactly. And sometimes a cervical collar can be helpful in the early stages. It helps immobilize the neck and reduce inflammation.
Okay, so we've got pain relievers, PT, maybe a collar. What are some other non-surgical things we can try?
In some cases, we might recommend a short course of oral corticosteroids like prednisone. That can help reduce inflammation and swelling around the nerve root.
Steroids can be really effective, but I know there can be side effects.
You're right. We always have to balance the potential benefits against the risks, especially with long-term use. So we typically reserve steroids for those cases where the pain is really bad, other things haven't worked, and it's significantly impacting their quality of life.
So we've gone through all these conservative options, but what about those cases that just don't respond? When do we start thinking about surgery?
Surgery is usually reserved for cases that haven't gotten better with conservative management after a reasonable amount of time, usually around if there's evidence of significant neurological problems like progressive weakness or problems with bowel or bladder control.
So those are our big red flags that tell us we need to call in the surgeon.
Exactly. We'd refer them to a spine surgeon to get their expert opinion and discuss the risks and benefits of surgery.
Okay, so we've walked through how we evaluate and manage cervical radiculopathy. Any final pearls of wisdom for us GPs out there?
I think the most important thing is to have a high index of suspicion. Remember, those degenerative changes we see on imaging, those are often there even in people who don't have any symptoms. So don't get too hung up on the imaging findings. Make sure they match up with the patient's story and your exam findings.
It all comes back to that good history and physical exam.
It always does. And don't forget about those provocative maneuvers. They can really help seal the deal on the
All
diagnosis.
right, noted.
Oh, and one more thing. Most cases get better with conservative management.
That's good to hear. I like those odds.
Right. Physical therapy, pain meds, maybe a collar, they can make a big difference. But we also need to know when to call in reinforcements.
When it's time to bring in the surgeon.
Exactly. Early intervention is key, especially if there are any neurological problems.
Okay, good advice.
Yeah.
So where are we headed next in our neck pain deep dive?
Next up, we're going to tackle cervical spondylotic myelopathy. That's when we have compression of the spinal cord itself.
Ooh, that sounds intense. I'm a little nervous.
I get it. Myelopathy is a little less common than radiculopathy, but it can have much more serious consequences. So buckle up, it's going to be a good one.
All right, welcome back to the deep dive. We've come a long way. Anatomy, everyday neck pain. We even tackled radiculopathy. Now it's time for, as you called it, the intense cervical spondylotic myelopathy. I have to admit, this one makes me a little nervous.
I can see why. It's definitely a condition where early detection is key because the stakes are higher. With radiculopathy, we're talking about a single nerve root, but with myelopathy, the spinal cord itself is getting compressed.
And that spinal cord is carrying signals for, well, everything, not just one arm or leg.
Exactly. So even though those same degenerative changes we've been talking about are often at the root of it, the symptoms can be much more widespread. And honestly, they can be pretty scary for patients.
Okay, so no sugarcoating here. What are the red flags that should send us running for an MRI?
Hmm.
What are those early signs that we, as general practitioners, absolutely cannot afford to miss?
One of the earliest and often most subtle signs is problems with gait and balance. Patients might not even mention it unless you specifically ask.
They may not even realize it's related to their neck pain, right?
Exactly. They might describe feeling unsteady on their feet, like they're going to fall, or their family might notice they're just clumsier than usual.
So it's not like they suddenly can't walk.
Hmm.
It's more of a gradual increase in clumsiness, maybe feeling a little unsteady.
Right. Maybe a wider stance when they walk or tripping over things more often. It's easy to dismiss these as just signs of getting older, but it could be something more.
Okay, so we're watching for subtle changes in gait and balance. What else?
Weakness is another key one, and it often starts in the legs.
So they might have trouble with stairs, getting up from a chair, things like that.
Exactly. Or even just walking short distances.
So neck pain plus new onset difficulty walking or weakness in the legs, that's a red flag.
Absolutely. And then there are those changes in bowel and bladder function that we talked about as red flags before.
Right. Urinary urgency, frequency, hesitancy, incontinence, constipation. We definitely don't want to ignore those.
Those are late signs, though. They usually mean there's already been some damage to the spinal cord.
This is sounding more and more worrisome. What should we be looking for on our physical exam to help us tell if it's myelopathy and not something more benign?
Well, besides those gait and balance problems, you might see what we call upper motor neuron signs. These are signs that reflect damage to the pathways that go from the brain down to the spinal cord.
Okay, remind me, what are those upper motor neuron signs?
Things like spasticity, where the muscles feel stiff and resistant to movement, hyperreflexia, meaning the reflexes are exaggerated, and a positive Babinski sign.
Ah, the Babinski. I remember that from way back when. You
Yeah.
stroke the bottom of the foot and the big toe extends up instead of curling down.
That's the one. So if we're seeing those upper motor neuron signs along with neck pain and maybe some of those gait and balance issues or changes in bowel or bladder function, that's a pretty strong indication that we need to be thinking about myelopathy.
Okay, no messing around at that point. We need to get them to imaging. Stat.
Absolutely. Time is of the essence here.
Mm.
And again, MRI is our go-to. It gives us the best look at the spinal cord and how much it's being compressed.
So, unlike radiculopathy, where we might try conservative management first, it sounds like surgery is almost always the answer with myelopathy.
That's generally the case. While conservative management might help with symptoms temporarily, it won't fix the underlying problem, that compression on the spinal cord.
So early referral to a spine surgeon is key.
Absolutely. The longer that spinal cord is compressed, the greater the risk of permanent damage. Early intervention gives the patient the best chance of a good recovery.
And what kind of surgery do they typically do for myelopathy?
There are a few different approaches, and the best option depends on where the compression is, how bad it is, that sort of thing. The goal is to create more space for the spinal cord, relieve that pressure.
So sometimes they remove part of the bone or disc that's causing the compression, and sometimes they fuse the vertebrae together to stabilize the spine.
Exactly. And with all the advancements in surgical techniques, these procedures are becoming less invasive and recovery times are shorter.
That's good to hear. Well, I have to say, we've really covered a lot of ground in this deep dive into neck pain. I feel like I have a much better understanding of the anatomy, the common causes, those red flags we can't miss, and how important it is to act quickly, especially when it comes to something like myelopathy.
I agree. I think we've accomplished our goal of giving you the knowledge and tools you need to confidently assess and manage neck pain in your practice.
I feel more confident for sure.
That's great to hear. Any final words of wisdom for our listeners before we wrap up?
Yeah, any parting thoughts?
Just remember, neck pain is super common, and most of the time, it's nothing serious. But we can't let those common conditions blind us to the possibility of something more concerning. Always be thorough in your history and physical exam. Pay close attention to those red flags. And if you're ever unsure, don't hesitate to order imaging or refer to a specialist. Better safe than sorry, right?
Couldn't agree more. Great advice. Well, thanks for joining us on this deep dive into the world of neck pain. We hope you found it helpful and insightful.
Absolutely. Thanks for having me.
And to our listeners, keep those brains engaged, keep asking questions, and we'll see you next time on the deep dive.